experience of our clinic from the Clinical Center of Belgrade.
Thank you, Professor Markovic. We thought in the program we should put a little bit some different topics, but also related to aorta, and this is why we wanted to present you our experience in acute aortic syndrome. Our institution is for decades 24/7 emergency vascular center, but since 2 years ago we officially got we were nominated by Ministry of Health as a referral emergency aortic center, which increased even more referrals to our hospital. As you know, the aortic syndrome is related to aortic dissection, intramural hematoma, and penetrating aortic ulcers, but also in the recently mentioned guidelines, thoracic aneurysm rupture and blunt aortic injuries also can be part of this syndrome. In the aortic dissection, the pathophysiology of the aortic dissection considers the making of two lumens and difference in pressure between them, causing malperfusion but also rupture. In this regard, the classification recently proposed by this working group, DISEC classification, we found very, very important because it is considering the pathophysiology of the dissection. So our indications are very connected to this classification. And in every type B aortic dissection, we measure the size of the entry tear. If it is more than 12 millimeters, we consider treatment. We also measure the true and false lumen ratio, and if there is a collapse of the true lumen, or if there is a very small true lumen, we consider intervention. And we also consider some other imaging signs of malperfusion, even though there is no obvious clinical signs, but we consider this potentially complicated dissection, and we very frequently indicate intervention in these aortic dissection patients. Treatment that we use in the last 5 years is implantation of the stent graft by covering the entry tear. And in last 5 years, we treated 45 patients with type B aortic dissection. As you can see, the indications were complicated dissection like visceral and spinal cord ischemia, lower extremity ischemia, and increase in diameter. But also almost 60% of patients were treated based on imaging and laboratory signs of complications. So there was no obvious complications, but imaging signs were indication that we do TEVAR in these patients. Technical success was 100%, but retrograde dissection we had in 1 patient, and we have in hospital mortality in 3 patients that presented with also the type B dissection and rupture. Intramural hematoma is a less frequent condition and less frequently treated, but we see a significant number of patients, and we consider indication if the diameter of the intramural hematoma is greater than 40 millimeter, if we see pleural infusion, and if we see ulcer-like projection lesions in this intramural hematoma. Of course, we do follow up in the first 14 days, and then if there is a progression in the morphology, we indicate also treatment in this patient. This is a patient that presented with intramural hematoma that very fastly developed dilatation, aneurysmal dilatation of the proximal section of the descending aorta, which was 54, and then in the next 3 weeks it grown up, it became 59, and then in the moment of treatment it was 70. Everything happened in almost one month. We treated 6 patients with intramural hematoma. In 3 we have to do carotid subclavian bypass. There was no mortality and no complications, at least early complications. Penetrating aortic ulcers, we treated 23 patients. Most of them presented with acute clinical presentations, but they were not treated in acute phase, but we decided treatment due to previous symptoms. And in almost 20% of them we did or proximal or distal visceral debranching in this patient. This is one of the patients with penetrating ulcers and a rupture that we did TEVAR, but this patient has very small infrarenal aorta, so we have to do aortic conduit through the laparotomy. We had several interesting cases in terms of combined pathology of thoracic and abdominal aorta. This is a patient that had almost thrombosis of the dissecting aneurysm in the infrarenal part, but he has a very narrow true lumen in the proximal section of the thoracic aorta. So even though we considered open repair in the infrarenal part, there was no good inflow. So we decided to do infrarenally endovascular with uniiliac graft and crossover. But in order to have a good inflow, we implanted also thoracic graft in the same procedure in the thoracic part of the aorta, but we have to also do carotid subclavian bypass. So we all did in the same procedure in this particular patient. Also, there was a patient with acute aortic dissection that was enlarging in the diameter, but also he has a concomitant huge iliac aneurysm, and he had also chest and back pain. So we decided to do in one procedure TEVAR and EVAR in this patient. We have, as traffic accidents are very frequent in Serbia, we had till now 28 patients with blunt aortic injury. In 2 we did carotid subclavian bypass. 4 of them died due to, or they were admitted with preoperative coma, or 1 patient died due to bleeding in the right hemithorax, probably due to rupture of the ascending aorta, even though we did technically successful TEVAR of the descending aorta. In 1 case, we had to do transaxillary implantation of the stent graft because the approach from femoral arteries was not possible, and due to very frequently unavailability of regular stent grafts, we frequently use aortic cuffs. Like in this case, we use 2 aortic cuffs or simple iliac extensions that are off-label use but save life in these patients. We have 1 migration of iliac extension during procedure that we corrected with another implantation of the stent graft. We had, regarding thoraco-abdominal aneurysms, we have 3 emergencies of conversion after TEVAR that had to be done emergently. We had ruptured dissection, and regarding the open repair, we had roughly about 40 patients with ruptured thoraco-abdominal repair that were repaired by open repair by our team with Professor Davidovic that do open repairs. In 1 of patients, as I mentioned, we had retrograde dissection that was treated with cardiac surgeons after TEVAR, and 1 patient had retrograde dissection that we decided not to treat. Patient was followed due to bad condition. He survived first 3 months, but later on he died from heart failure, not related to dissection, but it was a heart failure. We also had 1 semi-urgent patient who had previous thoraco-abdominal repair. He developed acute enlarging of the thoracic aorta. It was dissected and enlarging. It was 10 centimeters, and we decided to do TEVAR in this patient because of already performed open repair. And interestingly, after a few months, the whole 10 centimeter aorta completely disappeared, which was really strange. I never seen this. Even didn't find this in the literature. Our development of endovascular program started with our proctors 10 years ago, with our teachers from European centers that me and other doctors from my institution went for education. And of course, we adopted very, in the beginning, planning and sizing, which helped us a lot. And we developed a team that is not only related to surgeons, but to interventional radiologists, transfusionists, anesthesiologists, and technicians that work with us very enthusiastically. So thank you for your attention.
Thank you, Dr. Končar, for your nice presentation. Do we have any questions for Dr. Končar from the audience? I would like to give a comment on your lecture. One of the very clear and good indications for TEVAR are post-traumatic injuries of the descending aorta. And maybe I would like to ask our guests about their experience and their opinion. Those injuries are often associated with craniocerebral injuries, associated with intracranial hemorrhage. How would you treat those patients because of the possibility of intracranial hemorrhage, and on the other side we have to give heparin during even the endovascular treatment of the thoracic aorta? Do you reduce the amount of heparin during the TEVR, or?
Usually you treat when there is associated cerebral hemorrhage with endoprothesis, always with endoprothesis, the rupture of the isthmus, with very, very low dose of heparin.
So you put the dose?
Yeah. You decrease the dose of the heparin as much as possible. And but usually are complex cases because you have cerebral hemorrhage, abdominal lesion, liver lesions, and so on. So in this situation, when you have frank rupture of the isthmus, you do first the isthmus, first of all the isthmus, and with very, very low dose, and after what is necessary to do.
What was your experience after that? Did they got the progression of hemorrhage complications or not with low dose of heparin? No progress of cerebral lesion. Sometimes you are devastating lesion cerebral, so nothing to do. But usually when you have a limitation on the cerebral lesion, you are not a progression with very, very low dose of heparin. But I think that in some cases you do also this procedure with local heparinization. Also, local heparinization. What do you mean with very, very low dose? What is that very low dose?
2,000 units of heparin, 2,500. Or sometimes also local heparinization on site. Because the problem is not in central aorta on isthmus, the problem is local, on the iliac and femoral artery. So to reduce and to treat locally.
Okay, thank you. Thank you on your opinion. Okay.
Just to invite Professor Markovic for his talk.